Our group consists of Andrea Figueroa, Marshall Kilduff, and Ari Spence, and we will be unpacking the SAFER program, which offers prescribed pharmaceuticals as a safer supply alternative to toxic illicit substances. The SAFER program operates on the land of the Lekwungen and Wasanich peoples, who have stewarded these beautiful lands on so-called Victoria since time immemorial. It is important to acknowledge the indigenous peoples of this land who are disproportionately impacted by overdoses due to the harms of historical and ongoing colonization. Here's what we're going to cover today. The war on drugs has forced significantly more potent substances into the unregulated drug supply, such as fentanyl, carfentanil, benzodiazepines, and others. In 2016, BC called a public health state of emergency due to the rise in overdose deaths, and Victoria has seen some of the highest deaths in the province. With the COVID-19 pandemic onset in March 2020, BC poised for a drastic increase in deaths due to the cutoff of essential services and border closures disrupting the supply. On March 26, 2020, the BC Ministry of Health and BC Centre on Substance Use issued their risk mitigation guidance, advising prescribers on pharmaceutical medications to alleviate people's reliance on the increasingly toxic drug supply. Subsequently, ABI Health and Community Services used the guidance document to launch the SAFER program in Victoria, BC, Canada, with feedback from Solid Outreach Society and other stakeholders through funding from Health Canada's Substance Use and Addictions program. At first, the target population for SAFER was people using unregulated substances who were unhoused. After BC enacted its prescribed safe supply policy in July of 2021, SAFER evolved and expanded as more prescribers and pharmacies external to the program adopted the new policy. The current inclusion criteria for SAFER are 1. Having a dependency on unregulated drugs, 2. A lack of access to willing external prescriber, 3. An insufficient safe supply through alternative options, and 4. Interest in prescribed fentanyl options. Toxic drug poisoning inherently impacts systemically oppressed groups, particularly Indigenous peoples, people with disabilities, those in poverty, youth, and folks residing in rural or remote areas. While implementation consultations sought to meaningfully involve people with lived experience, and in particular youth, women, and Indigenous peoples, they failed to represent gender and sexually diverse individuals and did not do any population-based analysis. However, intake prioritizes Indigenous individuals, women, and gender diverse folks. It is apparent, though, that many service users still report barriers to access.
Our primary sources for this topic came from evaluation reports of SAFER, as well as recent studies by the Canadian Institute for Substance Use Research. These key documents were supplemented by academic literature on safe supply, evaluation reports of other safe supply programs, recent government reports, news articles, and course resources. Following Tannehill, we considered the available evidence and theory about safe supply through our ethical lens, specifically harm reduction.
The SAFER program offers pharmaceutical-grade opioids and stimulants through various forms as an alternative to accessing the unregulated drug supply, aiming to reduce the number of overdoses in Victoria. At its inception, SAFER operated through an outreach model, sending nurses, outreach workers, and systems navigators out to encampments to engage people living outside. In June of 2021, SAFER opened its own clinic and partnered with community pharmacies to shift away from the outreach model. Clients referred to the program go through an intake process with SAFER staff members to explain the program, establish goals, gather some basic demographics and experiential data, and sign a consent form before commencing with safe supply. The SAFER team also provides various social supports, including help with obtaining ID, housing applications, accessing programs like income or disability assistance, legal assistance, etc. Overall, SAFER describes itself as a program to affirm the lives and experiences of people who use drugs through a harm reduction lens by providing access to safer alternatives to the toxic drug supply and wraparound social supports.
Safer Victoria is a safe supply program rather than an opiate agonist treatment program. OAT employs Suboxone and methadone to address opiate addiction, minimize drug-related harms, and aid in sustained recovery. It is regarded by many doctors to be the first line of treatment for persons diagnosed with opioid use disorder. However, many people who use drugs have stated that it produces very little euphoria and can stop them from getting high on other opiates. Drug user activists worry this kind of war on euphoria will only lead to more overdose deaths. Safer supply involves prescribing medications as a safer option for individuals at high overdose risk, diverging from traditional substance use disorder treatments. Unlike these, safer supply services prioritize meeting drug users' needs, lessening reliance on the toxic illegal drug supply, and facilitating connections to health and social services when suitable.
As stated previously, SAFER was started by ABI, an HIV/AIDS service and harm reduction organization, in collaboration with SOLID, another harm reduction organization run by and for substance users and other community stakeholders after BC released their RMG. The collaborators released an implementation brief on the program and planning process. Ongoing community consultations help shape the program throughout implementation, including a concept mapping study with people with lived experience to help identify what an ideal safer supply program would look like. Currently, staffing resources include a diverse range of peer support workers, systems navigators, a medical office assistant, nurses, physicians, and street ambassadors. SAFER also has a leadership team, including a medical director, program manager, and clinical nurse lead. Additionally, the program relies on partner pharmacies, the necessary pharmaceuticals, clinic space, supervised consumption space, harm reduction supplies, and an electronic medical record system.
As mentioned earlier, Safer Victoria works with a client eligibility criteria and participates in referrals from their team, other service providers, and self referrals. The intake process involves information and consent forms, and the medications can be obtained from the Safer Clinic or a community pharmacy. The one thing to highlight is that the SAFER program created a more flexible clinical and prescriber guideline that was based on the BC risk mitigation guidance. Overall, the emerging evidence supports prescribed alternatives as a critical option on the continuum of treatment and harm reduction services for people who have not been successful with traditional approaches to care and who are high risk of drug poisoning. Health administrative data research provides reassurance on the safety of prescribed alternatives. Gomez Cola et al. Observed reduced health services utilization among those on prescribed alternatives, with no changes in infection rates, opioid related death, or all cause mortality. Sloan White et al. Found a 61% lower rate of death from any cause and a 51% lower rate of overdose death among those receiving prescribed alternatives. Those with 4 or more days of opioid prescription had a 91% lower rate of death from any cause and an 89% lower rate of overdose death. Stimulant prescription was not linked to acute care use, positively impacting healthcare utilization. The desired outcomes and impacts of Safer Victoria can be seen in the following charts. It is important to highlight that Safer Victoria has implemented regular evaluations of the program. They regularly ask their participants how their safe supply is working for them and the impacts they experience from having access to regulated drugs and program support. We can see that for the most part, there has been an improvement in the participants' lives from year to year. The success of this intervention. Preliminary program data has confirmed that SAFER reduces the harms of the contaminated illegal drug supply, and participants are experiencing positive impacts on their physical and mental health. Important indicators of success include reduction of a range of harms such as decreased cravings, withdrawal, safer use practices, and less use of contaminated illegal drugs. However, SAFER has not fully met all the elements of an ideal SAFER supply model as defined by people who use drugs and other key stakeholders. A full evaluation of SAFER is currently being conducted by the Canadian Institute for Substance Use Research CoLab team. Evidence-based Safer Victoria. Safer Victoria is a public health program that fits the evidence-informed decision-making model proposed by Seleska et al. The initiative has taken input from people who use drugs and advocates for safer drug supply to address community health issues. This approach is supported by emerging research and evidence based peer reviewed articles which guide health practitioners. Safer Victoria considers community and political preferences, actions, and public health resources. Evaluations of the implementation of the safe supply have been conducted through collaboration between the community, academia, government, and public health reports. However, longitudinal and randomized controlled trial studies are yet to be added.
The SAFER initiative has a number of strengths, including but not limited to its use of participatory planning methods, key partnerships, a focus on ethics, a growth mindset, and the development of a program specific set of clinical protocols and prescriber guidelines. As a cutting edge intervention, Victoria's SAFER initiative has faced their fair share of challenges. We have grouped these challenges into three interlinked categories: socio-political, which includes ongoing stigma against people who use drugs and the barriers this creates; clinical, namely the tensions between a harm reduction model and the requirements of prescribers' colleges; and logistical, including the limited physical space at Victoria's clinic and difficulties recruiting and retaining staff. As we learn more about the impact of SAFER and other safe supply programs, some common issues have emerged. First, there are obvious ethical challenges for conducting RCTs on safe supply. Next, the drugs provided in safe supply are often not meeting the needs of people who use drugs, as they cannot compare in their potency and ability to produce euphoria compared with the unregulated drug supply. Lastly, there is a clear need for widespread systemic change. Gaps in information. As SAFER is a new program, we still don't know what its long term impacts will be. Furthermore, there's a lack of research looking at the impact of safe supply versus other interventions, and between prescribed safe supply and grassroots programs that don't require a prescriber. There's also a need to understand the unique experiences of people who use drugs in rural and remote communities. Lastly, it remains to be seen how SAFER will adapt as the political and health context changes and evolves in the years to come.